If you look just for taking other risk factors, diabetes, it's interesting that there's absolutely no difference in the presence of plaque, unilateral or bilateral, in either age groups. When you look at this picture, I'm not quite sure what's great from that, but I guess that was a bit surprising. But again, I think it's interesting to show that risk factors are not the same as actual atherosclerosis. And finally, if we compare with coronary calcium score, and again, this is only present or not present, and you see the calcium score below. Those are the extremes, and of course, much higher prevalence of plaque than those without. On the other hand, coronary calcium score of 0, there was still a plaque presence of approximately 60 or 70%, bilateral was a little bit below 40, and to my mind, that tells us that carotid ultrasound is probably much more sensitive than coronary calcium score, which on the other hand is highly predictable of risk once you get up to the 500s. So if we look at our data a little more in detail, so we have, I said 80% of cases had a plaque in the either side, 52% are bilateral, and we actually had 3.5% with 50% of cases, which was more than 410 individual cases. Now, how can we use these data? Well, what we like to do is to get some kind of a measure of plaque size or burden. As I said, when we use the 2D, which we got in all 6,100, we don't have the accurate information in the third dimension, so we cannot calculate the volume. But we thought that why not try to make some kind of measurement which we could call burden, where we add the individual area in each of the slices that we measure. So we simply add each of the areas into a numeric number. So this is the distribution where we did that. Now for low plaque, the this isn't drawn, so that would be high up in the y-axis. But of course, you see in most cases have very small plaques, and then we've got more less and less of the more extreme one. And I think that this graph shows us that if there is any thing that the more atherosclerosis you have, the worse you should be off. We should find that in this group up here. And I, of course, expect this probably to be some of the most important or most exciting things to look at once we have endpoints enough. Another thing is the carotid plaque texture, something that we worked on for 15 years. This is something from a 10-year-old publication where we looked at doesn't matter if you have a echogenic plaque or an echolucent plaque in your carotid. And we quantified it by the same measure as here, grayscale median and median of the grayscale here. And this is the life table of 246 cases we followed for an average of 4 years. And it shows that carotid echolucency is more important in predicting who's going to get a stroke than degree of stenosis. Now we can do the same thing with this software. Here you see a carotid plaque, which is white, which tells us that a lot of calcium or a lot of fibrous tissue, and here you got more black or more dark gray each one. And you can see the grayscale median, the difference is very big, 149 versus 23. So here's the distribution. In the first 4,000 cases we looked at, a nice normal distribution, and again, we would expect that the events might be down at this end rather than at this end. And in fact, we actually know from Japanese studies of the texture in coronaries that the same thing is actually shown for coronaries and this for carotid. And also, if plaque texture is very different within the same plaque, it's also been shown in the picture of events. And on the left side here, you see a case where you've got uniform radius plaque. On the right side, you've got some more dark areas and some more white areas. Therefore, the standard deviation in grayscale median is very different. And we got a nice normal distribution of this also, and again, so we would expect that a higher end rate in this group over here. So what's the status of today or yesterday? Well, a week ago, we finished reading all the 2D suites of the 6,100 cases, and as I mentioned, this is still software development, so there are some miscalculations that we're looking into. That's going to take a few weeks. We began reading the 3,800 cases who had true 3D data last week, and we expect that's going to last the rest of this year. We have a reproducibility study at the IRB at this stage, and we expect to do that in the next few months. You may ask me, why did you undertake this big study without that? Well, that's because that our time to prepare this was very short, because study development was present, the whole study was ready to go just to INT. And then we were asked, can we do something for PAC? So we started this protocol without having a chance to do a true repro study. So we're actually doing that. But anyway, to calculate, to being able to evaluate if we're going to have better methods to discriminate between training and imaging, we calculate that we need to pick some endpoints, set the Maya stroke, and that should take us a total of 3 years and more than 1 year span. So within 18 months, probably we might be there. And then we'll probably be able to evaluate if 3D plaque quantification will be useful. And this is the group of people working with it. So thank you very much.
Okay, thank you. Excellent presentation. So quick question was that the definition of the plaque, it appears to be really the core of the matter. If you lower the bar.
We use the same definition as the one from the European IMT and the American Society of Echocardiography, which Pierre Chalon already alluded to. So there's no difference when we say plaque presence, it's the same definition.
Okay, and your device is not more sensitive or does not have more sensitivity to detect plaque than devices used in other studies, because that could also introduce another reason for higher burden.
No, I mean, we use commercially available scanners. I mean, obviously, we've done this study at year 2008, 9, and 9, and some of the other studies were done 10, 15 years ago. So, of course, there's been an improvement in technology, but I think the main difference is the method, how we used it, by using the more 3D-like approach rather than simply 2D, which all of us were brought up with.
Okay.
Yeah, when we had the correlation between 3D and 2D, we had in the studies the correlation between 3D and 2D.
Are you asking if there is a study that correlates 2D and 3D data because you have 4,000 measured both?
Yeah. There's going to be a study doing that. I mean, we've done that. Those are the same cases. So obviously we'll be able to say whether the 2D sweep is as good as the 3D, which you would not expect. But, it may actually be so.
Yeah. So the two, okay, go ahead.
Just real quickly, just one question. You showed the calcium scores. There didn't seem to be a very strong correlation between calcium scores and carotid plaque. In other words, there wasn't that big an increase going from a calcium score of 0 to a high score for prevalence of plaque. And I wonder if that's going to pose a problem, because we have a lot of long-term data that a calcium score of 0 is very low risk. But you show 70% of patients with a calcium score of 0 have plaque. So that would presume that plaque may not be a good predictor the way you defined it.
Yeah, no, I think you're touching a very important point, and I think what you should remember here is when we say plaque, yes or no, that doesn't discriminate if the plaque is 1 cubic millimeter or 100 cubic millimeters.
Right, so I think we need to redefine if we're going to use that data.
Actually, if he develops this tool, we would have, just like coronary calcium, we would have plaque score, and therefore, the higher the coronary calcium, the higher the risk. The higher the plaque score, plaque area or volume, the higher the risk.
But our definition can't be the presence of plaque then. It would have to be the presence of plaque greater than something.
That's right, just like coronary
Prevalence is
calcium. Just like coronary calcium positive is not enough. You have different
I
categories.
think once they get the outcomes data, it becomes there. And what threshold does it really become?
Henry, do you think we can have the outcome data, or you're studying AHA?
Years.
No,
2
I
years,
think that-
12 to 18 months.
There will not, I don't think there's not planned to be any outcome data at AHA, unfortunately. It's going to be these baseline data where we're comparing methods. I don't think we will have any points enough, and, strictly speaking,
But that's exactly the reason that we that
One last question.
One question for Henrik. How is it that, I know this is an older population, but you're predicting about a 10% event rate over a period of the next year and a half maximum. That seems like an extraordinarily high event rate. We're used to thinking about 20% over 10 years as being a fairly high event rate. You're now talking about 600 events.
Okay, maybe I wasn't clear enough. We're looking for 600 events in 6,000
said a year to 18 months on your
That's when
last
it's
slide.
due, the events are due.
That's when it's, okay, so over 3 years.
More than a year ago.
Oh, I see. Oh, so it's over a 3-year period, huh?
Thank you.
Okay.
Our final speaker this morning is Dr. Steve Feinstein.
10%.
Steve, 10 minutes.
Les, thank you
But
very much.
it is very, I think this is important. That is the reason, because the plaque prevalence is so common that, in our guideline, we are saying any plaque is a high risk. We have to really look into that and do something about that.
Yeah, I think you're on the money. He has the data, so it's shape 3.
Well, I would like to contribute to shape 3.5 then. This is a contrast-enhanced ultrasound imaging. It stands on the shoulders of those people who describe 2D, 3D, and it adds a component that I think you'll soon see is called neovascularization. This was featured on the cover of JACC Imaging. This is somewhere after 10 years of doing this work. It's nice to see it. Anyway, what are contrast agents? For many of you who don't know, they're small microspheres, 2 to 4 microns. They pass through the capillary, as you can see up here. That was actually performed by me in 1982. What you see here is a microbubble at 20 million frames a second. So you can see that the field has moved nicely forward. Now let's go into some practice issues. This is a carotid artery exam, as you can see. The contrast agent will enter from the left side through a vein, and this is the lumen. So as we begin to inject 1/2 cc of ultrasound contrast, you can see that the near wall is identified, the IMT, and the ulcerated plaque is identified. And this is all done intravenously, not intra-arterially, like I was questioned by the FDA cardiorenal panel by a radiologist said, did you stick the bubbles in the carotid artery? I explained that they actually go through the vein, through the lungs, and interesting people. Interesting, why do we use contrast? For the same reason we use it in cardiology. You can't see the distal components of the artery. So the common, the bifurcation, the internal are much better seen with contrast. Now, let me give you a specific case. This is a standard ultrasound exam, which is highly relevant. It's from this year, so good equipment. But this is the same patient with and without contrast. And you will see the near wall does contain about 20% thicker IMT, and that's where the atherosclerosis is. So this patient would be considered negative for IMT thickness, and here positive in the same patient. This is a little study of ours in Chicago. We've done over now 5,000 patients with contrast, but notice this is a very small little plaque. But in fact, the small little plaque is very, very vascular.
You've done 5,000 patients?
1,000 at Rush, and with Michael Davidson, 3 clinical trials with thousands of studies. So we can get into that in a bit. This is from the University of Rome. This is the adventitial surface of the carotid artery. This is a plaque that's not that vascular, but it's very large. So now I've shown you a very small plaque that's very vascular, and a very large plaque that's quite avascular. This is from Hans Westcott in Hanover, Germany. Notice this is a carotid artery with special software that's commercially available. This is not the plaque. This is the plaque. So this is positive remodeling, this is negative remodeling, and this is the degree of vascularity within the plaque itself. This is a patient from Milan. It is not atherosclerosis or diabetes, it's Takayasu's disease. So again, we see tremendous neovascularization in the intimal layer. So it's looking at atherosclerosis, inflammation, not just atherosclerosis. This is a publication we had in 2009 looking at some 157 patients retrospectively. We graded their degree of vasodesorption intraplaque. If they in fact had more vasodesorption in the plaque, they had 3 times the risk of a heart attack and stroke in a retrospective study. This is an animal study. This is a familial hypercholesterolemic swine. This is the femoral artery after grading the artery. Notice after the intravenous use of contrast, we have now created angiogenesis in the wall of the femoral artery using contrast. When we looked at that in a little more detail, this is the control femoral, this is femoral after abrasion. Notice the plaque looks very similar to that of a human, and in fact, these large animals have adventitial and vasodesorption growth very much like the human. Where does all this go? It ends up looking at this 3D contrast real-time image of a carotid artery with contrast for the lumen, to look at the plaques, and for the vasovasorum. Thank you.
Great. You get A for time management. Thank you. So I think what we're, and you're great for it. So the plan is to quickly take a break, grab lunch. Is that right? Monique,
Yes,
we have lunch ready?
outside.
Okay, and then come back here. Matt will be our first presenter, and everybody, every carotid guy, get ready to jump on it.
I think Paolo's going first, right? Paolo, you're up first? Yeah. I defer to Paolo. I know, but you asked us to Paolo.
I decided I'm doing some interviews with people about top line thoughts. Honestly, I'm not working on some related. Into what exactly? You just presented it.
I won't show this slide.
Guide me, which one of these is it? Is this the first? You have two set of slides? You have two set of slides? This is the one that we start with?
Enjoy.
Put her on the desk.
So the first speaker on the coronary calcium side is Dr. Paul Rodney. Some of you might know, but I want to make sure everybody knows. To my knowledge, he was the first to bring the name of screening in coronary calcium, and it's documented in PubMed. So can't be dubious faith. It's going to be hard for AHA, they thought of it first. But there you go. Oh, you'll take that podium. Do you have? Great. You need to turn it on.
Slides? Are you advancing the slides?
Yes, I'll do this through this one.
Okay, advance please. Advance. So what I've done is to answer the question, or try to answer the question that was asked to all of us, what is new since 2005? So I've tried to summarize for you a few of the publications that have expanded the field and possibly have brought some more light and enlightenment to the field. This is a publication on a subject we already dealt with, the elderly. And if you advance the slide, please. Nobody can read it, and certainly I cannot read it from back here. This is an example of, that's okay, I can have my own slides on my computer actually.
Well, why don't we just, is there any way you can move here? Sure.
The elderly have no calcium. Unfortunately, it's not very readable. This is from the internet, from the laser. And all you do is populate the questions here. So, for example, if you take a 78-year-old male, white male, and you give it a calcium score of 45, it will tell you what the percentile is for the individual. And it will tell you that only 7% of the population in this age range and this gender and race do not have calcium, so 7%. However, the story changes dramatically. If you now make this 78-year-old man a black man with the same calcium score, now 19% have no calcium. And if you look at a female 78-year-old female, black female, only 69% have calcium, so 31% of the population would not have it. Again, indicating that there are great differences in the, at least in the imaging detection of subchronic atherosclerosis, differences not only between gender, but also between races. And we'll talk about that again in a moment. So this is a publication that we released just a year and a half ago, dealing with the ability of coronary calcium to predict outcome, in this particular case, annual mortality in the elderly. And when we define elderly in this particular paper, over 70 years of age. And you can see that there's, this is annual mortality in general. Of course, it increases as your age increases. In the second slide, however, we show that calcium scoring works well as a predictor of outcome at any age group. Females are on the left, almost 18,000 females and 18,000 males, almost. And you can see the decrease in survival for increasing calcium score in any of these age groups. As you can see, the age group is on the x-axis, survival is on the y-axis, and the color of the various curves has to do with the extent of calcification. The survival is over 6 years. 6 years of follow-up. And as you know, now it has become, let's say, standard and almost fashionable to do, we also calculated the so-called reclassification index. The pink bars, of course, have to do with women in various age groups, and the blue bars with men. And you can see the number of patients that were reclassified, either higher or lower. I know that you cannot read the slide at the bottom, but it will tell you how many proportionally have been reclassified to a lower risk group or to a higher risk group. Just to give you an interesting piece of information, how many women at age 80 or above were reclassified to a lower risk group, 28%. How many were reclassified to a higher risk group, 70%. So interesting how this works. And it's reclassification index. Remember, these are observational studies. Almost 40,000 people collected between Tennessee, actually the West Coast with Matt contributing a lot of these patients, and some of the East Coast folks. So a portfolio of data and only dealing with mortality, not morbidity. This is probably the most classical paper. I know that you can't read it, but it has to do with reclassification of risk in the MESA data set. And this is the most recent publication, just came out a couple months ago in JAMA. The NAT reclassification index, just to remind everybody, is estimated as the number of events reclassified higher minus the number of events reclassified lower among those who did have an event, plus the number of non-events reclassified lower, the number of non-events reclassified higher, over the total number of non-events. So in other words, you take into consideration everything that went wrong and everything that went right when you added the new tool, the new piece of information. And so taking that into consideration, which in this particular paper, just to summarize, was model 2, in other words, adding calcium, resulted in a significant improvement in risk prediction compared with model 1 that did not contain calcium, with a reclassification of about 25% of individuals, either higher or lower. These are data from the MESA. Now, MESA is a study, as you know, that is retrospective. It's not randomized, it's obviously an observational study, but it will be all really blinded. These are, again, details from the same study, but it shows, without spending too much time, it shows that without doing anything else, this is the classification of risk. And once you know calcium, the reclassification switches a lot of the low risk into the medium and high risk. And in other words, this is before knowing, this is after knowing. This is in those who had an event and those who did not have an event. So in other words, there's shifting of risk to have a better definition of who's going to be at risk and a better definition of who's not at risk. That's what it is.
So the NRI that you define includes both shifting up and
And
shifting
down,
down.
yes.
Now, the 25% in Mesa, what percent of it was up? What percent, if you break it down?
I don't remember. I will have to
Because
read.
the coronary calcium that testing showed, it was 23%. It's ironic, it's so close. I mean, IMT. IMT was 23%.
And here we go. An additional 23% of those who experienced an event were classified higher. An additional 13% of those who were not without an event were classified lower. So that's the answer to your question.
36%.
No, that's the average of the two.
If 23% were classified higher, if 13% were classified lower, that becomes 33% total people reclassified.
36 you mean?
36%. Whereas in Eric, was it Eric? 38? That's ironic.
It's very similar, yeah, very similar.
Hello, was low risk 0 to 10% or was that 7?
Oh, risk here is at 5 years, so they defined it as 0 to 3, because it's 10 years up to 6%. So they consider 0 to 3 a low risk, 3 to 10 intermediate risk, and greater than 10 high risk. Because the follow-up is only 5 years in Mesa.
Paula, can I ask a question?
Sure.
As a clinician, what value of positive predictive value are you looking for before you consider a screening test to be clinically useful?
As a clinician, I never think about that. Now, if you're asking me as a clinician who writes papers and research papers, that's different. As a clinician, I don't think that anybody gets a flip, honestly. Now, that's the honest answer. If you're asking me what I would like to have, well, definitely I would like to have something that is about 70% positive predictive value.
So how many events were there in Mesa?
The events was something.
209?
220, 212, something like that.
Out of nearly 6,000 patients. So if you do the math,
It's
positive predictive value is about 3.55% for this broad category of composite endpoint. If you focus only on clinically relevant hard outcomes, we've got 122 events out of 78 patients. We get a positive predictive value of 2%.
Oh, for what?
For cardiovascular death, MIs, and
Of the general population, but that positive predictive value means you have to apply a test in there. You didn't add a test yet.
Well, that's the question I'm asking. That's why I prefaced my question. What degree of positive predictive value are you looking for?
Well, another way to look at it is, how does it add to the ROC curve, okay, which is significant, and that's been shown. But you got to realize that most tests, when you look from a positive, when you do a cholesterol test, we still think that's a valuable test. It's not a high positive value. If somebody has a 20% 10-year risk, that's not a very high positive predictive value.
May I add something from our study? I think that's an important question. We have a negative predictive value which is very high, but what is a positive predictive value? If you look to the literature, the best what you can predict for sudden death and implanting defibrillators is about 20%, roughly. And we looked in our data for the predictive value in high-risk people, meaning more than 400 or more than 1,000 calcium score. And then you come to a predictive value of 28%. And that is for, I think, for a clinical test in the general population tested a very high value, and it is as high as the current values which are used in the daily life for defibrillator implantation.
So what is the prevalence of a calcium score of greater than 1,000?
It's less than 1%.
So, I mean, I think we have to factor these considerations. We shouldn't be using the best case scenario predictions, but what is the most relevant in clinical practice.
Right, yeah, I think that's a very valid point.
10% was a score over 400, and what was the positive predictor over 400?
One was about 17, 18%.
About 17 or 18% for value over 400, and that's 10% of that group.
Yeah, that's more helpful.
Sanjay, I think the point is that it's the best available test right now. To say that to demand a high predictive value for a screening test is just totally unrealistic. And so we have to use the best available tools, and it's clearly superior to any risk factor-based analysis.
I think we're going to get to that point of comparison, but comparisons to the status quo. The status quo, and then come to the reality of what is available to us. What's the status quo of positive predictive value?
Well, I think the question I'm asking you is, as clinicians and as researchers, we have to ask ourselves, what is a good positive predictive value that we can live with? Right. And do we have any tools that achieve that positive predictive value? Just by saying that this is the best available we have is not good enough.
Right, but what is it that you're doing now, or it is recommended nationally that is practiced widely, is way below that what we can do and we're not doing? Don't you agree that we have the ability to improve a little bit? And that's what we're trying to do. A little. It's not huge.
20% is huge.
Your
point is correct.
Let me continue, otherwise we're never finished.
Yeah.
So this is actually finally, I'm glad to say that Dr. Herbal has gotten this publication accepted and is impressed. This is the main publication from the next lower study in Germany that has been going on for now 6, 7 years, 10 years. And several thousand patients enrolled, very, let's say, better than MESA European type of study. Same concept here, you can see the increasing event rate and increasing calcium scores, both in the low, intermediate, and high risk group defined by Framingham categories. And again, an increase, and there's a concept there that I don't remember exactly the data, but there is a reclassification ability here that you demonstrated. Anyway, the publication is in press, it's not available yet. And the difference is very important. MESA was designed exactly for that particular purpose. Interestingly enough, so far, unless I missed the publication, there is no publication that says that calcium works equally well in every race. What I mean by that is that it is predictive in every race, but does it work the same? So is a calcium score of 100 the same in each population analyzed? This is a publication we released just before the MESA, which I will show you in a moment. And the first observation we made, and this is a publication that came out simultaneously probably with SHAPE 1, we had data from Europe, from Portugal, as well as Brazil. So Portugal, Brazil, and North America. We had almost 20,000 pieces of information, 7,000 or 8,000 from each group. And we compared the calcium distribution and risk factors in these three populations. Notice that white people from, Caucasians from Portugal and Brazil obviously had a lot of similar backgrounds. So look at the distribution of calcium. This is quite interesting. The lowest in Portugal, intermediate in Brazil, highest in the USA, tracking the cardiovascular risk in each one of these three nations. I'm sorry, this is backward. This is not red. This should be calcium score excuse me. Red is mortality and blue is calcium score. But in other words, they track each other. They go in the same direction. The most interesting thing is that despite the fact that in Portugal they had the lowest calcium scores, intermediate in Brazil and highest in the USA, there was an interesting distribution of calcium by age. For example, for any risk, let's assume that it is a risk factor to be over 65 years of age. It was still lowest in Portugal, intermediate in Brazil, highest in the United States. And you can take smoking, you can take hypertension, diabetes, and it's still lowest in Portugal, intermediate in Brazil, highest in the United States, for each one of the risk factors. This one, for example, is hyperlipidemia. Again, lowest in Portugal, intermediate Brazil, highest in the United States. So, there is bad news to live in this country, I don't know. But whatever respect you have. So then we went ahead and looked at mortality. This is overall mortality in a large group of individuals, again with the contribution of the West Coast data mixed in with the East Coast data. We had, as you can see here, about 15,000 subjects. We had Caucasians, African Americans, Hispanics, and Asians at large, because we didn't have enough Chinese exactly as they define them in MESA. Non-readable curves, but the bottom line is the following. These are Caucasians, Hispanics, African Americans, Asians. Everyone died progressively more with more and more calcium. But you can see that the trends are quite different. The most impressives are actually in African Americans. But interestingly enough, they have less calcium than Caucasians have. They even have less calcium than Hispanics, but the mortality is different for each calcium score that you can compare. These are again mortality compared to Caucasians. How do the Hispanics, the African Americans, and the Asians did? This is for each one of the calcium scores. And again, it's obvious that the relative risk of for an African American is much greater than the other two races. Another way to express this is years of life lost, and I'll just show you one line here. If we take, for example, a calcium score of 400 or greater in an African American age 50, there's about a 9 years of life lost. Okay, about something like that. If you take an Hispanic age 50 with a calcium score of 400 or greater, the life is about 6 years shorter. If you take an Asian, it's about 5 years shorter. If you take a Caucasian, 50 years old with a calcium score of 100, it's only 3 years older, 3 years shorter. So in other words, the impact of calcium in each one of these races is very different from the point of view of expected life. These are the data from MESA, actually really, you can summarize them in one slide. And the slide shows again the calcium is predicted, but there is no definition by race here. And the reason is probably that MESA did not have enough events for each one of these various races to define the difference between a Caucasian and a black or a Chinese man. So all we know from MESA so far is that calcium is predicted in these 4 different races in both sexes. Unreadable again. All I want to show in these 2 slides, and I'm just summarizing verbally, is that there's a very different distribution of calcium per age, per sex, per race. And so when we talk about a calcium score, we should be very careful in defining what calcium score in what race and what sex we are talking about. This is indeed another of the MESA pages on the internet. They call it the calcium arterial age, and I'll read it from the screen because I can't even see it I'll read it from the monitor. I mean, here I give you a case of an Agatston score of 61 in a 56-year-old female. At the bottom here in green, it says that this lady, because of this calcium score, should not be considered 56 years of age, but rather 69. And based on this elevation of the estimated vascular age, her Framingham risk factor should not be considered 1% any longer, but rather 4%. That's a 56-year-old female with a calcium score of 61. Now if you take a 61-year-old male with the same calcium score, now the vascular age is again considered 69, not 56, and the Framingham risk score is elevated from 8% to 16%. So there's a change, there's quite a substantial change in risk. This is what we call implementation of arterial age, in other words, modifying the risk based on your race, sex, and gender. Age, race, and sex. Finally, a couple of mentions of non-coordinating calcium findings. This is thoracic aortic calcification. Does it predict mortality? Is it helpful? And we have a publication in atherosclerosis that does show, we see the difference in survival. These are Kaplan-Meier survival curves among patients without calcium in the aorta and calcium in the aorta. There was a statistically significant difference there. And actually, knowing that the calcium score was less than 100, but the patient had calcification of the thoracic aorta, increased the relative risk of mortality. And even greater than 100, calcium score greater than 100, in the absence of thoracic aortic calcification, or with thoracic aortic calcification, almost doubling of the risk, as you see here. And then the power of nothing. This is very important. It's a publication that, again, we put out with the usual suspects. Dan Berman here, and Matt Budoff, and myself, and Tracy Callister. We put together all our database with over 45,000 individuals and looked at the presence versus absence of calcium. What's the power of not having anything? And the power is extraordinary. I think that I highlighted here that for a person without presence of calcium, followed for the maximum of 80 years, the survival is less than the mortality is less than 1%. Less than 1% at the end of a study. These are untreated, yes. These are general walk-ins.
Well, no, walking, but they could get statin treatment.
Mostly are untreated, actually. Most of these people. Especially those without calcium. So here's survival without calcium, the yellow line, with tiny amounts of calcium, the red line, and then substantial amount of calcium, defined as actually greater than 10. This is in women, and the same exact curves in men, a little bit more accentuated. And the power of nothing is also useful in the emergency room. I put this up as a provocative slide, I guess, because there are a lot of CTA studies right now that show that patients without coronary calcium who come to the emergency room with chest pain, even with low risk, they have non-calcified plaque in 10% of the cases. So we actually did a study at Emory. This is one of our own studies where we did PET CT on everybody, CT for calcium, PET for perfusion. And we did it in about 250 patients. I don't remember exactly the number, but about 250. You can see here an example of a patient with absolutely no calcium and perfect perfusion. And the bottom line there was that 99 of 206 patients had no calcium, and of these, only one had an inducible ischemia on PET. This yielded a negative predictive value of 99%. So I don't know exactly what to make of the finding that patients with chest pain in the emergency room may have a lot of non-calcified plaque. The reality is that perfusion abnormalities are very rare, and the outcome is very good.
Did you see a distinction between asymptomatic?
No, absolutely. But these were symptomatic. These were patients in the emergency room.
Yeah, I think that sample size is probably
small. Yeah. So what will we give at Emory for $100, by the way? Our cost is $120. It includes fasting lipids, fasting glucose, blood pressure check, and a Framingham risk score. We give a total calcium score and calcium score percentile and a true and a vascular age of the patient. And we also include, as of a few months ago, epicardial tissue, adipose tissue volume, which I would like to show you in a second. I'll show you why we're doing that. Oh, sorry. So for those of you who do CT for calcium or for any other reason, you have epicardial adipose tissue within the same image. You really do not have to expose patient to anything else. The idea is that epicardial adipose tissue is really visceral fat that may be rather inflamed, very much like the abdominal fat that we're all concerned with. There actually have been several studies of patients submitted to bypass where biopsies of the epicardial fat were performed. And essentially the epicardial fat demonstrated, skipping quickly, a lot of, or more, let's assume, more and more inflammatory cytokines as the severity of coronary disease progressed. while the anti-inflammatory cytokines or the protective cytokines like adiponectin actually tended to decline as the severity of coronary disease increased. The theory is that epicardial tissue may be actually influencing the development of coronary disease by paracrine sort of effect. It can be measured by many different modalities. Echo, of course, can be used, but is the least accurate. Magnetic resonance can be used, obviously is more elaborate. NCT is very, very simple. I will skip through this just to give you a bottom line. Plenty of publications coming out on epicardial adipose tissue. There's one from MESA that actually shows that epicardial adipose tissue was an independent predictor of incident coronary artery disease events. So very interesting that it's already been published in this funny journal, actually, American Journal of Clinical Nutrition. I have no idea why they're there, but very important. I'm sorry?
Because of eat volume.
Eat in the American Nutrition, exactly. There are several other publications that actually have shown an association with CAD, both as coronary calcium, severity of stenosis, etc. For those of you who are interested in IMT, there's a MESA publication showing actually a relationship between epicardial adipose tissue and IMT thickness. However, this association was lost once you collected for waist circumference, indicating that maybe there was an association there between obesity and the noted association. We actually had a couple of publications on this subject. This one, we show that EAT volume is actually closely associated with the presence of mixed or non-calcified plaque on CTA. So the larger the amount of fat around your heart, the greater the probability of having non-calcified plaque, as well as calcified, but a lot more the non-calcified type. And finally, this publication that we released just a month ago, where we related the presence of EAT, also again epicardial adipose tissue, to ischemia on PET-CT. Remember, PET-CT is great because simultaneously you can do CT for calcium scoring and volume of epicardial tissue, PET for perfusion simultaneously. So you see here a patient with inducible ischemia of the lateral wall, and this patient had actually very little calcium but a lot of EAT. In other words, a lot of fat but very little calcium. To make a long story short, in this ROC curve, actually, we show that there is a better prediction of ischemia by using EAT volume than by using calcium. Calcium adds very little to the presence of a large amount of fat around the heart. So we would like to summarize saying that EAT may be something that we need to consider, even because it really does not require any special expertise. It's already on the images, and it really adds very little time to the imaging portion. I'm done with my presentation.
Thank you very much. We're going to quickly move to Matt Budov's presentation, and Matt,
I'll be short,
we're
we're
running
running
out of time.
of that stuff. So I just want to cover two topics, and then I'll turn it over to Harvey to talk about CTA. But one thing I wanted to show, and people don't appreciate the study for reasons I don't understand exactly, but I was going to talk about progression and calcium, but I want to show this one study. So this is a lot like Jupiter. Jupiter was a high CRP randomized to Crestor 20 versus placebo and followed for 4 years for these endpoints. Actually, Jupiter had one other endpoint, a hospitalization for angina, and showed that rosuvastatin lowers events in the presence of CRP. We have the exact same data here in the St. Francis randomized trial using calcium score at baseline. So calcium score above 80% at baseline, randomized to atorvastatin 20 or placebo. Endpoints are seen there, MI, stroke, death, and revascularization. And there was a 44% reduction in cardiovascular events. Heart attack and death went down by 44%. If you look at event rates reduced score above 400, and you can see the event rates in the patients with a score above 400 are very high, right? 4-year event rates of 15% in placebo. So if you start talking about Sanjay's point about positive predictive value, That's 4% per year. That's a very, very high event rate for a score above 400. And there was a 42% event reduction by using a statin. So calcium is both a very potent predictor of events and also a treatable target, if you will. If you have a positive score and you put them on what now may be considered modest therapy for an asymptomatic cohort, atorvastatin 20, you get a 44% or 42% reduction in events, and the absolute event reduction is even larger. The number needed to treat here was 16. 16 patients treated for 4 years resulted in 1 less heart attack or death. 16, nothing's ever been seen like this before in the statin world. There's no statin trial that's had an NNT of 16. So calcium is going to be, so far, based on all studies ever published with a statin, the best target of therapy if you wanted to keep costs down, because the number needed to treat is the lowest. Two other points related to baseline score, and then I'll just move on to beyond the calcium score and progression. One is it induces adherence. It improves your ability, or it improves the patient's staying on therapy. We can see compliance went up with high scores up to 90%. At 3.6 years, we followed a little over 1,000 patients for 3.5 years. Observational, we didn't bug them, we didn't randomize them to treatment, they were on a statin. We followed up with them at the end of the study to see if they were still taking a statin, and compliance went up with higher scores. And if you look at 0 scores in white and increasing to the highest scores above 400 in black, aspirin initiation, diet, and exercise all increased dramatically with the presence of coronary calcium. So it appears to be a good stimulus for compliance, which obviously would be helpful if we're trying to eradicate heart disease, because in the models of treatment, you have to factor in compliance. Alan Taylor showed this as well. Alan showed probably the most powerful data showing that you can improve adherence by looking at a 6-year follow-up in the PAC study, and he showed that patients were 7 times more likely to stay on an aspirin and a statin if they had a positive calcium score as compared to a negative calcium score. So matching intensity of therapy with intensity of risk, very important for our SHAPE algorithm. So I just want to show you a couple progression studies. Paolo showed some very powerful data related to baseline risk. What happens when the score changes? We saw some data, some very nice data earlier from IMT and the increased risk with progression. So this is 4,000 patients. This is all-cause mortality. About 10% of the population died over follow-up. And you can see the difference in mortality rates between non-progressors and progressors was dramatic. If your calcium score was staying about the same, within 15% of your baseline score, you had an excellent long-term survival. If your calcium score was going up, you had a much worse long-term survival. You're about 3 times more likely to die over a 7-year follow-up, average follow-up. Treatment was treatment was mostly statin therapy, but it was not a randomized trial, so we didn't mandate Lipitor 80 or 20 or something like that per patient. This was observational data in 4,600 patients. If you look at calcium score 0, it really doesn't matter. If your baseline score is 0, your long-term risk is nearly 0. And incident calcium, which was described here as progressors, it should probably say incident new calcium development from a score of 0, really didn't add much, so we couldn't show any value per se of remeasuring calcium here over 10 years, because even if you developed some calcium, it didn't predict mortality, at least as one endpoint. And then this is very similar. This was emulating Paolo's work that was published in ATVB in 2004, showing that this is increasing score, and this is non-progressors. So higher score, more death, but dramatically higher score with progression. So if you look now at what happens with progressors, calcium score of 100 to 400, now 20%, if they're progressors, over 20%, over almost 30% of them died. If the calcium score is above 400, over 40% of them died. So baseline score being high and progression, big problem. So we have some data there. Obviously, it was a retrospective study, and treatment was not controlled for. It was observational. So Paolo touched on some of the extracoronary calcium studies. I'm going to just touch on a couple others. Aortic valve calcium, already on the scan, a measurement we get for free. You can see in the middle there, the middle picture there, a lot of aortic valve calcium. And when you adjust, after controlling for coronary calcium, it's still at an incremental value. In MESA, you're about twice as likely to die or have a cardiac or coronary event, a cardiovascular or coronary event if you had aortic valve calcium. And after fully adjusting everything, the hazard ratio was threefold. So this is on top of calcium scoring. So you can get incremental value from aortic valve calcium. Paolo already showed incremental value with thoracic calcium, another free measure on the scan. And this was another study looking at the distribution of calcium, just going beyond a total score and saying, where is the calcium? Is it proximal? Does it cover a lot of the coronaries? And Elizabeth Brown showed in MESA that you can improve event prediction by 52%. So we may be being too simplistic in just saying, what is your total score? Although that's been what's been published most commonly. All-cause mortality, again, stratified by age, a 0 score is excellent. 25,000 patients, Paolo showed even more data than that. And I just wanted to show when you stratify by number of calcified lesions, just simply how many different calcified plaques are present, you add incremental value, another twofold predictive risk. So going beyond calcium score to aortic valve, epicardial fat, thoracic calcium, aortic valve calcium may all add incremental value. Paolo talked about epicardial fat, so I'll stop at that point.
The bottom line here is you go through the same x-ray, but there's so much information, more than just getting the coronary calcium. The cardial fat, distribution of calcium, thoracic calcium, the size volume of the heart, other things that Matt didn't put here. We put an NIH grant on this years ago, and we're still trying to get funded to actually come up with a comprehensive vulnerable patient score. Let's move on.
Just a quick question for Matt. Matt, if this was to be included in SHAPE 2, the issue of change in calcium score, is there enough data in different ethnic groups or genders and things to say something?
I think we'll have great data because MESA has scores at baseline and 3.5 years. And we're just doing, Nathan Wong and I are just doing the follow-up now because we had to wait for events after the second scan, so it's a little delayed from the baseline data. But I think we have some data from my group, which is multi-ethnic, the 4,000 patients, men and women, we can break it down by men and women. But we'll also have MESA, which obviously is 50-50 men and women, and 4 ethnic groups. So I think we could do that.
And would you anticipate it to be very different between the groups?
No, I mean, so far, it all seems calcium is bad, and if it's in your coronaries, it's bad. So it seems like we can't find a real, once it's there, a calcium score of 100 is equally bad if you're black and female or if you're white and male. So it might not be that different on the process.
Matt, are scores of 0 in a non-coronary vessels just as predictive, as high negative predictive value as elsewhere?
So if you said no aortic valve calcium
or no thoracic.
Or thoracic calcium, so calcium in the coronaries always trumps extracoronary calcium in prediction. So if you had a positive calcium score and a 0 thoracic score, you'd still be at high risk. So I would never forego the calcium score per se. But these other things seem to add incremental value, and that's something that we'll need
when they're positive,
Raymond to do in his cohort now. A lot of extra measures to make on his 5,000 scans.
Thank you, Matt. Harvey, we're going to go fast, please.
This is